All right. Good evening, everybody, and welcome to our February Autism 200 lecture. First of all, I'd like to welcome the Federal Way School District, who are going to be joining us for the first time this month. And tonight we're pleased to have Dr. Golombek here. She's a child psychiatrist from the Seattle Children's Autism Center, and she's going to be talking to us about medication management and autism.
Hi, I'm glad to see you all. So when I first decided to do this talk, I talked to one of our staff members who has a child who is also affected with autism, and I said, what is the one thing that I need to know from a parent perspective? And she said, you know, we resisted medicating our child for a very long time because we didn't like the idea of medicating our child. And I realized that I think the perception of what I do from the public standpoint is probably a little different than what I actually do and what all my colleagues actually do. So I wanted to take us a little bit through how child psychiatrists are created and how we think about helping your child. And then within that context, we're going to talk about medications specifically. But as you're going to see, it's really embedded in an awful lot of other things that are going on in our mind at any given time. So when people think about a child psychiatrist, we will be talking about medications. When they think about a child psychiatrist, sometimes they think about kind of Freud with, you know, tell me your dreams, tell me about your mother. And sometimes they'll think about us as kind of mad scientists about to do trials on their children. And neither one of those is obviously true, but actually in some ways both are somewhat true. From the tradition of psychiatry, we really do take the idea that children are incredibly complicated individuals and that we are watching them develop over time, and that process of development is actually quite important. The other thing we take from the tradition of science is a very specific way of looking at evidence. So we really do try to identify and characterize a particular problem. We try to figure out why is that problem happening. If we're thinking about an intervention, we intervene and then we re-look at the data and we say, has that helped this child? Because if it hasn't helped the child, then we need to rethink the situation. We need to rethink either what we thought was wrong to begin with, or we need to rethink our intervention. And that turns out to be incredibly important. So when you see a child psychiatrist, really, what are they? Well, we generally all go to undergraduate school. Then we go to medical school, and that's 4 years. And then we take a bunch of examinations and then go on to our internship and our residency in adult psychiatry. And that's usually 3 or 4 years. And then we do 2 years in a child fellowship program. So that's usually somewhere between 5 and 6 years, although it's an additional 2 years and nights and weekends, I once calculated. And then there are additional research and training. And so some of my colleagues have actually trained in pediatrics. I've had a fellowship in neurodevelopmental education, and other of my colleagues have done research. And then we go through a board certification process that can be fairly extensive, and then you come and see us. So what is autism? Those of you who are here for Dr. Bernier's talk have a much better idea of what autism is. But from my perspective, it really is a range of complex neurodevelopmental disorders. And it's characterized by certain things that are in common, specifically the difficulties in social communication and the restrictive repetitive behaviors, as well as some of the sensory sensitivities. But it's not any one of those stripes. So under the umbrella of autism are any number of kind of etiologies or variants that we're going to determine over time. And this makes research exceptionally difficult because we're not talking about this particular thing that applies to all children. We're talking about a huge range of individual children, all of whom have various things that are very different, but also have some similarities. We know that those variations occur in a lot of different areas. It can occur in terms of onset and course. It can occur in terms of risk factors, the severity of symptoms, whether there are intellectual deficits, the degree of speech and language a child may have. We also see significant variations in terms of medical and neurological conditions, as well as the presence of psychiatric disorders or symptoms. And the important thing here to recognize is that there's no one cause, partly because there's no one autism. And so therefore there's not going to be one cure or one specific medication that's going to answer every child's difficulties. So how we help your child is we kind of take that into consideration, and typically you are referred to us, often from people that you are already working with. And that's often the ideal situation because you're already seeing psychologists or behavioral therapists who are incredibly important, speech and language therapists who are absolutely essential, occupational therapists, or maybe you're referred by your pediatrician, your neurologist, or somebody else. What we then try to do is to take into account all of the issues that your child is facing and come up with a plan. And the way we do that is to kind of do our traditional evaluation, and I'm going to give you an idea of what that looks like after I kind of talk about a couple of kids that are based on some of the kids that I have seen. So the first one is Sam. Sam is obviously not that old, but having had that frustration with computers, I thought that actually brought a lot of things to bear. It turns out to be very sensitive to sound, and he resists going to music class. And whenever his parents tried to make him go to music class, and music class with a bunch of 12-year-olds is going to be a cacophony of sound, he would yell and he would scream and he would kick, and if they tried to intervene physically, he would kick them and run out of the room. We also found out that he tends to have these meltdowns when he's told to do certain things, like to get off of Minecraft, or to do very basic things like take a shower. Aiden is another very sweet child. He has some pretty significant developmental delays and very limited language. When I first saw him, he was biting himself to the point of bruising. He was hitting his parents and his siblings, and then really seemed to feel really quite dreadful after he did so. But he'd also started to hit the teachers and the peers at school and was having some pretty significant behavioral meltdowns. Those meltdowns seemed to occur whenever he was transitioning from one activity to the next, whenever there was a change in the routine, or things that weren't expected suddenly popped up, or when he encountered a new situation. And they also tended to escalate when people tried to give him a timeout. And the third child is Susie, and Susie is just a total ball of energy. This is a very, very happy 7-year-old girl, but she was not learning well in school, and she was extraordinarily energetic. She could not sit still for more than I would say half a minute or a minute, would bolt out of the room, would run across streets if she saw something that interested her, and had very little concern or understanding of safety. And she also had very limited attention, particularly for anything that was not screen related. So what do we first do? Well, the first thing we're going to do if you come and see us is a psychiatric evaluation. And what we're going to ask you is we're really going to ask you to try to think about the particular thing that you're worried about most with your child and really drill down and characterize it. We're going to want to know, well, what are you seeing that seems to be the problem? Is it a problem with behavior? Is it that they've lost their sparkle? Is it that they seem to be having a very difficult time transitioning to school? We want to know, when did it start? We want to know, was that a sudden thing or was it a gradual escalation of a problem? We want to know when it happens now, and we want to know how long it's going to last, typically. We want to know what's made it better in the past. What interventions have you tried, and what's made it worse? We also want to know if you have tried certain things, if you've tried times outs, or you've tried anticipating transitions, or you've tried, say, medications prescribed by somebody else. How effective have they been? Have there been anything good in terms of results? Have there been things that you've seen that you didn't like, that you were concerned about? And then we want to know, how that particular problem is affecting your child. Is it just affecting the child in the home, or is it in school and everywhere else? So that ends up being exceptionally important. And last, we really want to know if there are any safety concerns, because when there are safety concerns, then I think that takes us to a different level. We may also ask you if your child has other kind of psychiatric concerns and how they were treated. We're probably going to want to know a lot about the medical history, particularly the neurological history and the cardiovascular history often. We're going to probably want to know how they're doing in school and what kind of supports do they have in school. And we may ask you about your family psychiatric and medical history, because that often has some relevance when we're thinking about kids both diagnostically and in terms of treatment. So after we gather all that information, we may even gather more. If the problem seems to be one of learning or of function, we may do specific assessments that are going to ask you about how your child functions in daily living. Are they able to brush their teeth? When you send them upstairs, can they get ready? Do they know what money looks like? Are they safe at home? Can they call 911? Do they have friends? How do they engage with friends? And those are really going to give us an idea about how your child functions at a particular time. We also may ask for something called, we often refer to as neuropsychological testing, where we're really looking at certain kinds of intelligence and often something we call executive function skills. Executive function skills are, think of it as kind of the big secretary in your mind. It's the thing that allows you to pay attention. It's the thing that allows you to transition your attention. It's the part of your mind that allows you to be organized and remember all the boring details that you have to remember in a day's life. It's also the ability to kind of control your body and your mind. And so when you think of something, you just don't say it. A lot of the kids that I see, kind of what comes to mind comes to mouth, and there's no screen. There's no pause in between the thought and the action. And executive functions really are at the heart of that difficulty. And we may want to have specific speech and language assessed, because clearly if speech and language is either perceived as too high or too low, then we're going to have some difficulties. And last, we're probably going to want to know from school as well as from home how he's doing. When the problem's emotion and mood, we may do different kinds of rating scales that really go after specific kinds of anxiety or anxiety in general, and also for depression. Now, when the problem is behavior, and I would say that's probably the number one reason people are referred to see me, this gets very tricky. And there are a couple of things that I really want people to understand. The first one is that mood and emotion and function and capacity, those executive function skills I talked about, often underlie behavior. So when we think about behavior rarely comes out of the blue. And when it comes out of the blue, I worry about different things. But most behavior is not random. It happens repeatedly. Sometimes it happens repeatedly in a kind of steady state. Other times it happens repeatedly as a child gets older, and as they get older and bigger, it becomes more of a problem, but the behavior was there for a very, very long time. We need to look at behavior as in two lights, I would say. The first is an active communication. And this is especially true if your child doesn't have the capacity to identify their emotional states, isn't able to tell you if they're in pain, isn't able to tell you when they're frustrated. They are going to tell you all of those things. They're just going to tell it to you in terms of their behavior. And usually behavior means I'm telling you that I'm either hurt, I'm in pain, or I'm in distress. I'm scared, I'm overwhelmed, I'm frustrated, I'm mad, and all of these emotions are boiling over me, and I can't control them. And it comes out as behavior. The other thing to look at is function. So typically, children will do something over and over and over again, either because we put them in a situation in which case they're overwhelmed, that's kind of the first, or it's working for them. It may not be working well for them, and it may not be working for you at all, but at some level, if they're doing it again and again and again, it's probably meeting a need. And usually that need is either I get something that I want, and often that's attention. or it's getting out of a situation I find distressing. So if the way I usually think of it is that, you're in a department store and your child pitches a fit because they want a toy. The moment you give in to that and they get a toy, they've learned something. And they probably haven't learned it in the front part of their brain, but at some instinctive level they've learned, oh, if I really want something and I pitch a fit, I get a toy. What happens then is that the next time you're in that situation and they want something, what do you think is going to happen? Well, you're parents and you're going to go, no, we're not going to go down that road. I'm not going to give in. And your child is going to, at some level, kind of think, well, maybe it's just because I'm not pitching a loud enough fit or a long enough fit. And eventually, parents are going to give in because they're human. And the moment that you've done that, you've reinforced that cycle. Similarly, if a child is in a distressing situation and they pitch a fit, we often will take them out of that situation, and at some level that has really worked for them. So if we put that child, for instance, who is very sensitive to sound, in a 12-year-old music classroom where everyone is banging on drums and he pitches a fit, and we remove him from that situation, then pitching a fit was actually very effective. It was an effective strategy to get him out of that situation. So when we're looking at behavior, we always need to think about both, have we put a child into a situation that's just simply overwhelming, and then also, what are they getting out of that situation? When we have none of those clues, and when things come out of the blue, then I worry about pain, I worry about hunger, I worry about sleep, I worry about something medical, constipation, seizures, illness, and I also worry about trauma. So if things come out of the blue, then that's when I get very worried. Usually that's not the case, and that's why if your child is presenting to us with some concern of behavior, we're going to probably ask you the same kinds of questions we did initially, which is, what does the behavior look like? How does it occur? What makes it better? What makes it worse? Does it come on suddenly, or is it a gradual progression? How long does it last? How severe is it? Are there any safety concerns? And are there any mediating factors? And there's actually a very good book that I like, which is this Functional Assessment and Program Development for Problem Behavior. It's actually meant for therapists, but I think it's a really good book to tease out what behavior may mean. And one of the ways that we do that is we try to figure out, well, when is it likely to occur? Is it, say, first thing in the morning, whenever you're transitioning, whenever something unexpected is occurring? And then we want to know, well, what happened just before the behavior? What seemed to set it off? And parents almost instinctively know, when Johnny seems to be hungry or tired, this is going to be more likely to happen. And I know if I tell him this, then we're going to have a problem. And then you want to ask, well, what are the reinforcing factors or the consequences? So what happened immediately after that behavior? Because that's going to tell us if we're dealing with something that is functional and if that was successful for that child. Okay? And once we've gathered all of that, now we're going to really think about how to help your child. And I really want you to pay attention to this slide, because as you see, medications are a very small part of the framework in which we think. And one of the things I think that's often misperceived is to say, oh, I'm going to a psychiatrist and we're automatically going to put my child on medications. That can't be farther from the truth. We're going to consider medications, but we're going to consider medications in the context of all of these other aspects of function and intervention, because if we don't, they're not going to be effective. So what do we look for? Well, the first thing I want to know is I want to know if a child is having difficulties, is he in an appropriate placement? I want to know, are the demands that we're asking of him a good fit for his abilities? And if not, there are some very practical stuff that, your grandmother would tell you. She would tell you to kind of use visual aids and simplify tasks and use hands-on learning. She's going to tell you to, prepare a child for transition and decrease all of the distractors. Where we start to look beyond that is we start to say, well, do we need some more neuropsychological testing to really know what your child's abilities are and where they're really struggling? Because if they're in a classroom that is At too high a level, that's going to be incredibly frustrating. And if it's at too low a level, it's going to be incredibly boring. And either way, it's not going to work out. And then we're going to want to know some very specific symptoms that really suggest a problem in those executive function skills that I talked about. The second thing I'm going to want to know is communication. Can this child tell me things? And what can they tell us? When a child's communication is very limited, that one of the most important things is to give them an ability to communicate. And if we can do that with words, that's wonderful. If not, the picture exchange communication system is often incredibly helpful. Because imagine how you would feel if you could not tell people what you wanted, if you couldn't tell them if you were in pain, if you couldn't tell them what you were worried about. So the ability to communicate is absolutely essential in solving so many problems of behavior and also a great deal of distress of that child. And again, in talking to a child with autism, we're going to try to use very simple language. We're going to avoid nuance. We're going to use a lot of visual instructions, and we're going to try to be very calm and very clear. We're going to use short sentences and be calm and clear. We're also going to look at socialization, because socialization, particularly for children who are on the higher functioning end of the spectrum, is a very significant aspect of their lives. We're going to look to see how are we preparing children for various experiences, and those social cartoons are often incredibly helpful. Do you guys know what those are? Do I have anyone who doesn't? So the social cartoons are little cartoon strips that rehearse various settings. So it's what happens when I go to the dentist, or what happens when I go to a museum, or it could be as simple as this is how I brush my teeth, or this is how I get ready for school. And what it does is that it's a visual reminder of what things are going to occur. And so a child doesn't have to be in that situation for the first time. They've effectively seen it before. And these can be very, very helpful. The other thing we're going to look for is some role playing and some buddy groups for kids who are on the higher end of the spectrum. And then we're going to look for stressors. Our kids are very sensitive to perturbations in their environment. So any stressor, even stressors that don't seem to be particularly stressful for us, may be exceptionally stressful for them. So if there's a change in the aide at school, if there's a change in the teacher, if there is an environment that they find overwhelming. Cafeterias are often very difficult. Auditoriums first thing in the morning when all the kids are crowding in. The bus can just be incredibly overwhelming. Similarly, putting them in situations that require transitioning, and that can be transitioning from one activity to another, so I have to stop what I'm doing and then move on, or it can be transitioning from one place to another. And similarly, I really want to look at the frustration of a child, and I want to see how he's able to cope with that frustration. And last, I want to really look at supports. And this is the child's own coping skills, but it's also what supports exist for the family and what supports are in the community. Very often I see kids where parents have felt very uncomfortable coming to see a psychiatrist, and by the time they come to me, they're exhausted because they've been dealing with a particular problem for years. It's gradually gotten worse. Children are often bigger. They're often stronger, and now parents have become very worried, and they're profoundly tired. And my one concern in that situation is that I often need a parent to now do things that are very hard. I need them to engage in a level of behavioral therapy that is often very tiring in and of itself. And so if I have one plea, it's come and see us early. Come and see us before the situation has gone on for such a long time that you've exhausted all your other options and you've been dealing with this on your own for a very long time. Because we can actually do some really quite wonderful things sometimes. The other thing I look for is I look for sensory seeking and sensitivities. Our kids are often extremely sensitive. They're sensitive to noise. They can be sensitive to taste. I have kids who can tell you exactly the brand of margarine that the parents are giving them. They are often very, very sensitive to scratchy tags. And yet at the same time, I've seen kids walk barefoot over Legos and not flinch. So that sensory sensitivity can go both ways. We can also see a lot of behaviors that are maladaptive. So sometimes you'll see kids who are chewing on their fingers or scratching their skin. Sometimes they're so sensitive to taste and texture, they will eat 5 things and only 5 things. And so for all of those situations, I think it's important to consider those difficulties in the context of kind of common sense solutions. And occupational therapists are usually very, very helpful with this. Sleep is another thing I need to know about, because sleep problem.
Occupational therapists are useful for doing what?
They're very helpful for helping a child with sensory sensitivities. So a child who, say, is having difficulty being overwhelmed by noise, they often come up with very practical solutions to help that child deal with that situation. If it's possible, they will also help a child acclimate to those particular things that are concerning. So for instance, in the child that I had who was sensitive to sound in the music class, to be honest, I don't really care if he goes to music class. I do care that he can get on a bus, because that bus is going to really tie into his future function. And so working with an occupational therapist to acclimate to the crowding of a bus, the noise of a bus, and using certain techniques like having the earmuffs ends up being very important. Being able to listen to your own music. So again, these are very common sense solutions, and occupational therapists are usually really good at that. So sleep. Sleep is, I can't tell you how often I have problems with sleep. So sleep problems are really, really prevalent in kids with autism. 44 to 86% of kids with autism will suffer from sleep problems. It's often presenting as a sleep onset delay. So this is the child who you try to put them to bed at 8 o'clock and it's 10 o'clock before they even start to fall asleep. Or they start to fall asleep, but then they're up again in 2 or 3 hours. And right when you're in the middle of your deepest sleep, that's when they seem to wake up, and then they don't seem to need to go back to sleep until maybe about 4 or 5 in the morning. And then you have to get them up at 6:30 to get on the bus, at which point they're seriously grouchy because they've only had, 4 or 5 hours of sleep, and your mood isn't particularly better either at that point. So one of the things that we have to look at is we have to figure out exactly what's going wrong with sleep. I want to know if a child is very restless before or during sleep, because that can sometimes indicate restless leg syndrome or another disorder. I want to know if there's any snoring or apneic events, and that's when a child gasps or stops breathing. In those situations, I may want them to see one of our sleep specialists, because obviously if a child isn't getting good rest, nothing else is going to be happening that's good either. So the child is not going to be able to learn well. They're going to be crabby. They're going to be more anxious, less able to cope with the stressors in their own life. And restoring useful and restful sleep is often one of the most important things that we can do, and often one of the most difficult. And you guys have there's a sleep hygiene handout that takes you through the basics of sleep hygiene. Often for our kids, we need a higher level of intervention. And sometimes that intervention tends to be medications. One of the first things we tend to try is melatonin. Melatonin is an over-the-counter supplement, which, as we all know, may or may not contain melatonin, although they didn't test for that one. And so I think it has to be used with some due caution. There are some studies, not the greatest studies, so they're not double-blind, placebo-controlled, randomized crossover studies, and we'll talk all about that. But there are some studies, and I think with working with a child psychiatrist, working with your pediatrician at very reasonable low doses, it's certainly something that we often explore. But again, it's an over-count of the supplement. We're not entirely sure what's in it. And sometimes there is a role for other medications, and we can talk about that later. What I'm going to ask you to do is hold the questions until the end. I'll probably take a break in the middle, and then we'll take most of the questions at the end. Nutritional and gastrointestinal problems. These are also very common in our population. Our kids tend toward restricted diets, often bland carbohydrates. However, malnutrition is rare. Some of this may be because they are exceptionally sensitive to taste. And that also may limit the willingness to try new foods. If I'm sensitive to texture, I'm probably not going to want to try carrots after I've tried apples. And it's often reinforced by the fact that, you're tired and you want your child to eat. And at some level you go, okay, if they're going to eat white bread, then at least I know they're eating white bread. And so sometimes that reinforces that pattern of eating things that they're only comfortable with. In terms of the question of dietary sensitivities, that's actually fairly controversial. I think that we're going to talk about it a little bit later in terms of how I approach that. But I think it's important to know that we don't have any consistent, strong, conclusive studies at this point to support any particular dietary intervention. The way that I look at it is I first ask, is this going to do harm? So if a parent says, I want to restrict sugar from my child's diet, well, I'll tell them that when we looked at sugar and, for instance, ADHD, we actually didn't see any link. That said, if every time you see your child get really hyper after they've had a bunch of sugar, the first thing I would say, well, under what conditions are they having a bunch of sugar? Is this something that they're doing every day, or does it happen only when they've been to Chuck E. Cheese's or to a birthday party? Because there may be other factors that explain that behavior. But if we say, well, it does seem that whenever he has a lot of sugar, it just doesn't go well. And so I'll say, well, is that going to cause any harm? Probably not. Now, it may cause some social issues if he can't share in the birthday cake, if he goes to a birthday party, or he can't, have Halloween candy. But if we're mindful of that, then let's do a trial. Let's identify those things that we think we see. Let's go off of sugar, because do we really, is that going to hurt him? No. And then let's collect the data, because it's often very difficult to limit something from your child's diet, particularly if your child has a limited diet to begin with. And then 2 or 3 months later, let's reevaluate the data and see whether or not you think that that made a positive impact. And if it did, then you know that the hassle of doing that is probably worth it. And if it didn't, then you have a better understanding of what may or may not impact that child's diet. But that do no harm, that's actually quite important. There are lots of different kinds of theories out there, and David Eaton will be speaking to a lot of those. But the way that I would say that we're all trained to look at that is look at it scientifically, come up with your hypothesis, run your trial with good data, and then reevaluate. And if it is something that seems like it could do harm, that's where I would have a lot of reservation in trying it. Now, some gastrointestinal conditions, it's completely the opposite. If you have a medically diagnosed condition of celiac disease, then that is on the opposite side, and we really do need to eliminate gluten. But that's a medically diagnosed condition, and we can be fairly certain of it. We also have to think about other kinds of effects on the appetite, and one of those is appetite suppression from medications. So some of the medications that I use can suppress appetite, and some of the medications I can use can really increase it. And we always have to weigh those when we're thinking about the effects on a particular child, because if your child hasn't eaten anything for 10 hours, my guess is they're going to be pretty cranky. And similarly, if they're on a medication that makes them really, really hungry at the end of the night, and they need to get up in the middle of the night to raid the refrigerator, that's going to be an issue as well. And last, I think it's important to know that we do see a higher prevalence of GI issues in our kids. The prevalence is somewhere around 70%, which is higher than kids who have other developmental disorders. That's about 50%, and higher than kids who have no particular neurodevelopmental disorder. And I think that's around 30%, but don't quote me on that one. So we do know that some sensitivity in the GI system exists. The last thing I really want to look at is pain. Pain is often something that occurs when you see a new behavior or when you see a sudden worsening of behavior. So if you see that all of a sudden a child is starting to hurt himself, hurt other people, refuse to toilet, refuse to do anything they used to do fairly easily, and the behavior doesn't seem to have a function to it, that's when I worry about pain. Often our children are very difficult to examine. They may not have routine medical care, they may not have routine dental care, and often for very reasonable reasons, because you would have to sedate a child. Although I think most of us would strongly encourage you to have all the normal things that every other child has. But as a result, they're a lot more likely to have things that we don't know about. So headaches, earaches, toothaches, stomach aches, those are often the cause of behavior that just seems to come out of nowhere. And it's often difficult to identify that if a child isn't able to verbally communicate that, or they don't have an icon for pain. If they're not able to comply with routine medical or dental exams, and if they have difficulty identifying facial expressions. So in the hospital, we often use the Wong-Baker Faces Pain Rating Scale. And the problem is that if you don't recognize those faces and what those faces mean, then you can give them to a child with autism, and they may point to the wrong one and give you the indication that they're not experiencing pain when they actually are. The other thing to be mindful of is that sensory discomfort, being in a room that's too bright, being in a room that's too hot, too cold, being in a noisy environment may be perceived as painful. So their threshold for tolerance of those things may be so low that what to you and me would just be kind of an obnoxious environment would to them be a high degree of discomfort. And last, we think about medical and neurological conditions. So I always want to know if there are any genetic comorbidities for a child. I want to know what underlying medical conditions they have. Sometimes certain conditions like thyroid conditions can actually present as psychiatric concerns. And similarly, if a child is ill, if they're having asthma, if they're on medications for a lot of illnesses, all of those can actually affect behavior. We also need to know about some other underlying concerns because that may impact what we can give as an option for medication. And we may need to do some medical monitoring. The other thing we always need to keep in the back of our mind is the neurological workup. So I always consult neurology if there is an unexplained loss of skill. So if all of a sudden your child who could tie his shoes and dress himself one day can't do it the next, and you don't have a plausible explanation of why that's the case, and that goes on, this is where I get very concerned. And this is where I want a neurologist to see this child, at least as pediatrician and then possibly a neurologist. And I also want to remember that seizures are really prevalent in our kids. They occur about 1/3, but it's in a bimodal distribution. So kids often will have seizures before the age of 5, but they can also have them around adolescence too. And so if all of a sudden you see that there's a sudden decrease in function, or you see behaviors that you never saw before, that's one of the things to consider. And the last thing I want to look at is I want to look at what medications is the child on and if he's taking any supplements. Because sometimes those medications, even though they're prescribed or used for the best of intentions, they have adverse effects. And they could cause children to become disinhibited, so very silly with very little impulse control. They could cause them to be agitated or really irritable, could cause confusion. And it can also cause some physical symptoms such as changes in the sleep pattern, their appetite, their heart rate, etc. And this is also important with the over-the-counter supplements. It's often very difficult to actually learn what is in a particular supplement, if it's a naturopathic supplement or an over-the-counter supplement. And I wish we had better resources to tell us what was in those so that we could figure out if there are any drug-drug interactions. So just be mindful of that. And now we come to psychiatry. So after thinking about all of those things, now I start to think about the specific areas that I tend to look for. And those are symptoms that range from ADHD, which are deficits in those executive functions that we talked about, anxiety, which is incredibly common, we're going to spend some time on that, depression, which can also be common, reactivity and self-harm and aggression, which often tend to be the presenting concern. And then things that are far more rare, like bipolar disorder and primary thought disorders. So as you see, kind of medications are getting smaller and smaller and smaller and smaller. When we think about kids, the way I think about them is that kids have certain biological capacities and they have certain predispositions. When that interacts with the environment, that interaction either reinforces something or makes it less likely. One of my biggest concerns is I often see kids when they are not 5 or 6, not 7 or 8, but when they're 14 or 15. And in retrospect, we realize this child has been struggling with executive function deficits all their lives. They've always had difficulty controlling their impulses. They've always struggled to pay attention. Or they've always had a great deal of anxiety when they've approached things like transitions, when they've been separated from their parents. And these difficulties have now interacted with the environment to limit their ability and limit their world further. When that becomes an issue of behavior, it's often meltdowns, tantrums, sometimes self-harm, sometimes aggression. But there's been a reluctance to think about a full range of interventions until the child is now big. And by the time I see them, they've had 6 or 7 or 8 years of both living with these struggles and interacting with the world in a certain way with them. And sometimes then we see things that they've learned to do, certain maladaptive behaviors that, again, at some level have worked for them. Intervening at that point is a lot more difficult, and it tends to be less successful than if we can intervene early. So what I would really hope that you get out of this lecture is the idea of considering intervening early, have this discussion with a psychiatrist or your pediatrician early rather than later. And we're going to talk about what that actually means. So psychiatric symptoms and disorders in kids are very difficult to determine. We don't know a whole lot about them. Part of the reasons we don't know a whole lot about them is because of all those varied presentations of autism that we talked about. So your child is going to be different from another person's child, and figuring out exactly what seems to be underlying their distress and their dysfunction is actually quite challenging. It's also challenging because often they can't tell us how they're feeling. They're not likely to come to you and say, Mom and Dad, I'm experiencing a great deal of general anxiety, I'm tense all the time, and I'm worrying about things unnecessarily. They're probably not going to say that. Even if they are neurotypical, they're not going to say that either. It's also very difficult to sometimes differentiate the psychiatric symptoms from the symptoms of autism. And this is where kids can very easily be misdiagnosed. So if you see a child who has, or a teenager who has poor eye contact and a flat affect, which means they have very little expression, or they're socially withdrawn, they don't have very many friends, and they have very concrete thoughts, so that if you ask them a question of, if I say to an autistic child, do you hear voices? Chances are that child is going to say yes, because he hears my voice, right? He's being honest, he's being accurate. If I say, do you hear voices? He will say yes, because he doesn't understand the context in which I ask them that. If I come to you and you are seeing a psychiatrist and I say, do you hear voices? You probably are going to say no, because you understand what I'm asking. And so kids with autism will often tell us the literal, honest truth. And that literal, honest truth can be misperceived as a problem that doesn't really exist. And they will be incredibly honest about it, which is one of the reasons I love working with them. Another thing that can be very difficult to determine is it a repetitive behavior or is it an OCD behavior? So we're trying to tease all of these things out to figure out, well, do they seem to kind of fit a certain pattern that in psychiatry we've identified as a specific kind of problem? And that is often difficult. And then it comes to treatment. We're trying to figure out how are we going to intervene. Well, there are very few studies for a lot of interventions. We need to tailor what we do know to a developmental level that's appropriate for them. And we also know that our kids tend to have differences in the response to medications. So what kind of treatments do we offer? Well, we really do look to evidence-based therapies. Have you guys heard that term, evidence-based therapies? So this is really looking to those therapies that have a pretty significant research background to say that they work. Now, no particular therapy is going to work all the time, but we do know that some tend to work far better than others. The one that we most recommend is something called applied behavioral analysis. And ABA is really a way of looking at an intervention, and it's very similar to what I described at the beginning of this talk, where we come up with a hypothesis of what we think is causing the problem, we come up with an intervention, we do the intervention, and then we reevaluate, and we see, is this working? And if we need to break things down into very tiny steps and then chain them back together again, then we're going to do that. But it really is the idea that we're going to look toward functional gains, and we're going to monitor that and monitor the response of our interventions, and we're going to adapt. It's not simply one kind of shoe fits everybody. Similarly, behavioral therapy comes very much out of that same tradition of figuring out, well, what is the problem? Why is the problem occurring? Is it that it's being triggered by this situation? Is it being reinforced by this result? And how are we going to change that? And then there's something called cognitive behavioral therapy. And cognitive behavioral therapy is the primary therapy for anything that's anxiety related and anything that's depression related. And it basically is a fancy way of saying that your thoughts and your behaviors and your emotions are all interrelated. And what we really try to help kids with is we help them with the thoughts that tend to reinforce anxiety and patterns of anxiety, and reinforce depression and the patterns of depression, and the behaviors that do the same things. And it tends to work. In fact, for typically developing kids, for anxiety and depression, it tends to work about as well as medications. The medications that we think about are a whole array of medications. And they can be most commonly things that we use for ADHD, and those are things like the stimulants, sometimes the non-stimulants, the medications that we use for anxiety and depression, and that is traditionally something called the SSRIs, or selective serotonin reuptake inhibitors. And sometimes we use other medications like the benzodiazepines. Those are things like Klonopin, mood stabilizers. You may have heard that term. We'll talk about that a little bit later. And sometimes things called neuroleptics or antipsychotics, which sound a little scarier. One of the things that's important to understand when we're thinking about medications is that, to date, no medication can target the core symptoms of autism. So that intrinsic problem of social communication and the repetitive behaviors, we do not have a medication that targets that specifically. We also have very limited studies, and we also know that of the studies that we've done and of the collective clinical experience, that in children with autism we often see less positive effect of medications, and we often see more adverse effects. So the way that we tend to think about medications is always part of that comprehensive strategy that we've talked about. It's always subject to evaluation and reevaluation. And it's only after weighing all the risks and the benefits and the alternatives and really going through the degree of informed consent that we need to go through. So what I would say to you is that when you're coming to see a psychiatrist, you're coming to see us to help think through all of the things that may be getting in the way of your child's function, what's causing the distress and the dysfunction. And then if we think that we're thinking about a medication, it's really a partnership. Because we may consider something, we may say, well, we think that your child has some fundamental difficulties with impulsivity. And we know that kids who have this particular problem sometimes respond to, say, Ritalin or methylphenidate. So how are we going to do that? Well, we're going to know what our data points are. if we're going to start a medication, we're going to start it really low. In fact, most of the psychiatrists and the RNPs at the Autism Center, we will start medications that are usually at the dose that we would normally start at a preschooler. And that doesn't really, even if they're older, we'll usually start at an exceptionally low dose, because our kids are often sensitive, and what we really want to know is what is the response to that particular medication. And then we're going to reevaluate. And if you come back and you say, wow, this has really been helpful, well, that's wonderful. Often, that's not the case. Often parents come back and they say, well, I don't really know. Some things seem to be a little bit better, but I'm a little bit worried about this. And then we say, okay, so let's take it to the next step and let's monitor. And as we go along, we're monitoring and monitoring and monitoring. We're evaluating, we're reevaluating. And we're really having a kind of appointment to appointment look at how your child is doing with those particular medications at a given time. And if they're not working, well, then why would we continue to prescribe them? We usually don't. And if they are working, but they're not working well enough, then we often try to see, well, can we do something that's a little bit better? So it's really that ongoing process of working with the child and mostly with the parents to figure out how we can do the most good throughout a long period of time, not just in one particular meeting. And that's why I usually say that when you're prescribing medications, you're doing it with humility, because if medicine teaches you anything, it's like we know so little. Even though we know a lot, we know so little, and we really have to be humble in our approach to every child. So I'm going to stop right here before we go into specific psychiatric disorders and medications and ask, are there any questions? And are there any questions in the remote field? I know you all are out there, but I don't see you, so it's hard to tell. Okay, then we're going to go on. So,
You say that there's no medication for ASD.
Yeah.
What is used?
We're going to get there.
Thank you.
Yeah. So, and we do have some studies that are specific to our population, and we're going to go through those. So the first thing I want to talk about is something called attention deficit hyperactivity disorder. And have most of you all heard about that? Okay. So ADHD is really a collection of symptoms that falls into 2 or 3 domains, one of which is attention, one of which is impulsivity, and one of which is hyperactivity. And I'll show you the symptoms that we usually use as a checklist for all of those in a second. But fundamentally, attention is how can you focus your attention? How can you keep your attention focused when there are things that are distracting outside in the world and maybe distractions of your own thoughts? Can you be organized? Can you get things done? Can you turn your assignments in even if things are long and boring? And also, can you shift your attention? So if you start with one thing, can you stop that thing and then move on to the next? When I think about impulsivity and hyperactivity, to me, that is a matter of can we control our body and our speech and our mind? And that's when we're confronted with things that make that sometimes difficult. So when I think about the hyperactive child, I want to know, is this the child who, cannot sit still and he's wiggling back and forth? Is this the child who you could be the best parent in the world, but if they see something across the street, that's where they are. They are bolting out of that room. Is this the child who tends to say whatever comes to mind? There's no filter whatsoever. Is this the child who's getting into trouble because they're chatting in class and they're talking to their peers? If so, this raises the question of whether there's this thing we call ADHD. We know that those symptoms are going to vary. So if I have that child in a situation where they're the only one in the room and they've got my total attention, or they're playing Minecraft, which they can play for hours at a time, or it's something that's interesting and novel, often their attention can be very focused. Not always. For some kids, they even have difficulty under those circumstances. But for a lot of kids, they can actually do quite well if those conditions exist. most of us realize that that's not normally life, and that life has an awful lot of unstructured settings, like not the classroom, but recess, that there are often kind of rather boring or difficult things that we need to learn how to do, and that we're actually expected to do a lot of those things either on our own or in large groups, where there isn't a one-to-one person helping you through your math homework or get through a presentation. So those symptoms can vary according to location, which is why we will often ask not just for your perception of how the child's doing in home, but also in school. And we know that this type of problem, which is very common, we think maybe somewhere between 3 and 5% in the population at large, and then up to a third in our kids, causes a lot of problems. So at school, children are often described as being inattentive. And when a child is not paying attention, they often become very disruptive, either because they're chatting when they're supposed to be quiet, or they're up and running around, or they're simply the quote-unquote space cadet, and they're simply not focusing. At home, what you often may see is that child procrastinates when it comes to doing homework. If the homework is difficult, they don't want to try. Even if they do the homework, there are little mistakes that they knew all along were little mistakes. Sometimes they will do all of the homework and then forget to turn it in the morning. And often that will create a dislike of school, because if I have to go to, say, a job where I don't feel I'm doing well, and I don't really enjoy it day after day after day after day, eventually I don't really like that situation. So we try to avoid that. At home, parents often complain that, I tell him to go upstairs and get ready for school, and I come up and he's got one sock on and he's playing with his Legos. And it's not because he's being obstinate, and it's not because he doesn't want to go to school. It's that he just kind of got distracted by this shiny object on his way there. Often parents will say, I have to be on him every moment of the day. I have to always have him in line of sight, because he could run off and doesn't really look, doesn't pay attention to the fact that there may be cars on the road. And parents will often say he will have meltdowns. And those meltdowns can happen whenever I say no, or whenever I tell him to do something, or if his brother annoys him, or if something goes wrong, he'll just have a meltdown. And I'll usually say, and how does he seem to feel after the meltdown? And often they'll say, he looks like he's unhappy. Sometimes parents will say, well, he seems to be remorseful. He seems to feel very badly. He may apologize for the meltdown. Other times they just say he seems kind of sad. And whenever I hear that, so it's not this kind of, you didn't give me what I want, I'm pouting, I'm mad sort of thing. It's more of, I just couldn't contain myself and I just kind of exploded and I feel really awful. Often that kind of distress indicates ADHD to me. And with peers, this is also a problem, because peers often think kids who have ADHD are very irritating. They're often bossy. They're often kids who are very easily annoyed, and so they're easily teased, and kids can be quite merciless in this. And they often seem very immature. We know that kids tend to make up their mind very early in the school year about kids who have ADHD. And unfortunately, even if you treat the ADHD, kids often will not change their mind during that school year. So they can be pretty harsh judges. So for all of those reasons, ADHD is one of those things that I really want parents to consider, because it's pretty common in kids with ASD, and we actually know a good deal about it. So I'm going to leave this slide in here because it gives you an idea of those kinds of concerns to think about. And if you see those in your child, I would urge you to bring it up with your pediatrician and say, this seems to be true, this seems to be true, this seems to be true, this seems to be true. And it's not just at home, it's at church, it's at school. And in retrospect, these are things that we've been dealing with for some time, because these are the hallmark symptoms of ADHD, and they're often things that we can do something about. So, what is the treatment of ADHD? It kind of falls into two categories. If the impairment is mild, we will often look to behavioral therapy or parent management training, so kind of teaching a child how to behave even when things are difficult. Typically with kids with ADHD, that's rewarding positive behaviors. So kids with ADHD often don't really do well with negative consequences. They like to have immediate rewards, and the closer you can time those, the better. We'll also look at classroom supports. So this is something as simple as sitting in the front of the class if they tend to wander with their attention, sitting in the back of the class if they need to fidget, sometimes having fidgety toys so they can fidget and not disturb others. Other times it can be a higher level of intervention. And then there are medications. And to be honest, medications tend to be the most effective. They are among some of the most effective medications that we have. And these are medications that you've probably all heard of. So they come in two categories, stimulants and non-stimulants. And I kind of think of them as within the stimulant family, two families. I think of them as the methylphenidate or Ritalin family. And methylphenidate comes in lots of different forms. And those forms allow you to target a certain period of time. So 4 to 6 hours in a short-acting medication, 8 hours in a medium length medication, and 10 to 12 hours or more in a longer acting medication. And then methylphenidate's cousin, which is dexmethylphenidate, that's Focalin, and that comes in a short and a long. And then we have the other family, which are the amphetamines. And typically most people think of Adderall and Adderall XR. And again, that's a short and a long. And then the latest medication, which would be Vyvanse. And Vyvanse is related to the amphetamines. And then we think of the non-stimulants. And the non-stimulants also kind of come in two different categories. One is something called Strattera or atomoxetine. And the other ones are actually blood pressure medications that we have been using off-label for years, and that now have been reformulated into longer-acting formulations that have FDA approval for ADHD. So all of those medications have FDA approval for ADHD, but we don't typically have studies on our population. Fortunately for methylphenidate, we do. So there's something called the Autism Network Research Units of Pediatric Psychopharmacology. Fortunately abbreviated as RUP because I would have a hard time saying that each and every time. RUP studies are typically excellent. They're multi-site, double-blind, placebo-controlled studies. They are of kids who are very similar to the ones that I would treat. I think they are very good, reliable studies. And the one that we have with 72 children with autism and ADHD, we saw a response in about 50% of the children. Inattention, distractibility, hyperactivity, and impulsivity were most improved. The response was small to medium. It didn't help irritability or lethargy or stereotypies or inappropriate speech. If the dose was too high, social withdrawal actually worsened. And the adverse effects were significant to cause 18% to stop taking those medications. And those could be things like becoming irritable, or having insomnia, or having decreased appetite, or having more outbursts. When you compare those responses to children who are typically developing, and this is one of the biggest studies of typically developing kids with ADHD, you'll notice there's a significant difference. So 50% response rate versus roughly 75. And that discontinuation rate, take a quick look at that, because 18 versus less than 2. That tells you that our kids are especially sensitive to medications. And that's why often if you're working with us, you're going to find that we're going to start a very low dose, and we're going to be very conservative in how we think about that medication. The second disorder I really want to spend some time with are anxiety disorders. Anxiety is incredibly common, I think, among our kids. And it may be provoked by things that normally wouldn't provoke anxiety in most kids. So transitions, changes in routine, new social situations, difficult task demands. I have children who are so focused on when things need to occur in a particular day that if they're late in traffic, that will cause tremendous anxiety. I have kids who, if their aide is not there that day, if they have a different one-to-one or a different support staff, that can cause incredible anxiety. And often I see my kids tend to be sensitive to just the general feeling of anxiety in the family. And they tend to pick up on that without really realizing what's going on. In the higher functioning teen, we often see kids who realize that they don't fit in so easily as they may have thought they have. And we may see any number of symptoms. So in a typically developing child, you may have symptoms that make a whole lot of sense, but in a child with autism, particularly if they have lower communication skills, it may look like kids being afraid or just being agitated. It may look like they are irritable and they're just having a whole lot more meltdowns. It could look like aggression. We could see an uptick in self-injurious behavior, hitting one's head, slapping oneself. Sometimes it's strange fears that come out of nowhere. Other times it's saying the same question over and over and over and over again. Or for every new thing, just getting stuck on that particular new thing. Sometimes we'll see a lot of repetitive behaviors, drawing on the same, in the same coloring book the certain way. Other times we'll say, children will say, it has to be exactly like this. It has to be like, you have to read the book exactly the same way. And sometimes we'll see specific movement patterns. Other times we'll just see kids being incredibly exhausted. The way that I look at this is that I try to imagine being in a foreign country. I try to imagine being in an uncomfortable situation, like being at the airport. I don't understand the language. I don't understand what's expected of me. I know I have to get to a plane. Something has to happen. People are yelling at me. They're telling me what to do. And in that entire experience, I imagine being completely overwhelmed. And I think often my kids are often overwhelmed on a daily basis. And if you think about it, they often seem like they're walking on eggshells, that the least little thing, the least little perturbation to their day can set them off. And when I hear that story, I really start to wonder about anxiety. Because I think if the world is a difficult and unpredictable place, and so therefore I want the most amount of control that I can have, right? So I want things that are extremely predictable, then it's going to bother me a lot more if something unpredictable happens or I feel I have no control over it. So please don't underestimate the power of anxiety. Some of the absolute worst meltdowns I have ever seen were fear-based. And I think that they are often at the heart of a lot of a child's distress and a lot of the things that we end up perceiving as problems. I love this quote from Temple Grandin, where she says, "It was a constant feeling of stage fright. Just imagine how you felt when you did something really anxiety-provoking, such as your first public speaking engagement. Now imagine if you felt that way most of the time for no reason. It was like my brain was running at 200 miles instead of 60 miles an hour. And imagine how incredibly exhausting that is to live in that world day in and day out." So these are a list of other kinds of anxiety, and they're drawn from our DSM and typically developing kids. And so what I would say is that if what I've already described sounds similar to what you see in your child, that's where I would say to my pediatrician, I'm starting to wonder if anxiety is something that my child is having to contend with. And then I would go through some of these symptoms, and I would say, well, does he seem really easily worried? Does he seem worried about silly things or excessively worried? And this often happens in a child who has a fairly advanced level of intellectual abilities. In a lot of kids, they have a lot of difficulty separating from parents. So this is the child that wants to sleep with you. They may go to bed after a long ritual or after you've been in the room so that they can fall asleep, and then if they wake up in the middle of the night, they're creeping back into the room with you. They may have trouble going to school. They may have scary dreams. They may have physical problems. They may have headaches or tummy aches when they have to go to school. And if you see kids who, if they're in the midst of a meltdown and you put them in their room and their meltdown escalates, ask yourself the question is whether or not is there some separation anxiety going on at the time. Because often these kids like to see you in line of sight. They feel a lot calmer if they know where you are. I've also seen panic attacks in our kids. Typically that's something that happens really, really suddenly. Sometimes we know why, sometimes we don't. And there's a lot of physical sensation that goes along with that. Sometimes we'll see social anxiety where kids will feel very shy and just incredibly uncomfortable when they feel like they're being observed. Other times we'll see issues of trauma. And trauma can certainly happen in our kids. And perhaps for things that would cause a little trauma in other children. I notice with a lot of my children is that they have an exquisitely good memory. So my kids can tell me, 3 years ago in this supermarket, this lady said nasty things to me, and they're right. I mean, they actually are completely right. So they have this incredible factual memory of things that were traumatic, which is why if we ever do a blood draw, we try to do that blood draw in the nicest way possible, because I know the kids are going to remember it forever. And I try to make that experience in our facility as pleasant as possible, because they're going to remember it. When a child starts to have nightmares or starts to have a lot of physical distress, they seem very physically uncomfortable, physically agitated, or very emotional at things that remind them of that trauma, that kind of makes us think about PTSD. And last, we can have something called obsessive compulsive disorder, although that's often very difficult to tease apart from the repetitive behaviors and thoughts that we see in autism, where you have just kind of these ideas that pop into your mind that don't make a whole lot of sense, that you have to do kind of magical things to make yourself feel better or go away. And if they start to sound like they have to do with certain rituals that have to be a certain way, or rituals of cleanliness, or concerns about germs, or having to have things just so, then that starts to raise the question of OCD. Now, how do we treat them? Well, cognitive behavioral therapy. And our therapists are especially skilled at taking cognitive behavioral therapy and making it into an appropriate, developmentally targeted intervention. And I've seen some of my patients benefit hugely from CBT. But it requires some skill, because you're really having to target it to the level. One of the handouts that you guys have gives you some great suggestions for CBT resources. And one of the books that I love most is the Huebner book. And it's the Huebner book. You'll see it on the list. It's about how tomatoes grow and how worries are like tomatoes, and what we do that makes worries grow and what we can do that can make worries not grow so much. The other thing that tends to work are SSRIs. So those are medications that you probably have all heard about. So things like sertraline, which is Zoloft, fluoxetine, which is Prozac, citalopram, which is Celexa, and there are a couple of others. Problem is that we don't really have a whole lot of studies in kids with autism, and when we do, it's usually not targeted to anxiety. It's usually targeted to something else like repetitive behaviors. We know that our kids are more likely to experience hyperactivity or restlessness, and sometimes we see this in something we call SSRI activation, which can happen when you start the dose or you increase it. Sometimes we'll see other symptoms along the course of time. So sometimes you can see some elation or irritability or insomnia. The younger the child, the higher the dose, the more likely you are to see adverse effects, and that's true for all kids. So again, we're going to be humble, and if we do decide to try one of these medications to see if we can target anxiety, we're going to do it low and we're going to do it slow. And if things work out well, we're going to be very grateful, and if they don't, then we're going to stop the trial. So things that can help, we have pretty good evidence that these work for anxiety in typically developing kids. Often those studies are drawn through OCD, but I do think that they pertain to anxiety in general. And I think just simply because a child has autism doesn't mean that they shouldn't have access to the data that we have for typically developing children. It just means that you have to be more cautious and just a little bit more humble. So depression. Depression is also considered to be more common. Usually we see it in adolescence, often with higher functioning kids. And this is when they realize that they're different and they're not fitting in and they're having difficulty forming friendships when they want to form friendships, or when things are getting more difficult academically. And again, how it presents may be very different than how you would expect it to present. Sometimes you will see a child who seems miserable or unhappy or is crying a lot. Other times parents will say, you know, the sparkle is off. He just doesn't like things that he used to like, or he just doesn't like them very much, as much as he used to. Kids sometimes will complain of feeling lonely or unloved. Often they won't tell you this, but if you give them one of the rating scales that we often give, they will answer these things very, very honestly. Kids will often feel like every other kid is better than they are, that they can never do anything right, that they're not good enough. They'll think that they're awful, or they'll feel very guilty. They think that they aren't very good. They'll hate themselves. Other times we'll see physical symptoms. We'll see that they're tired, or they're restless, or they can't focus anymore, and sleep can go up or down. In kids with ASD, we may see other symptoms. We may see kids who are withdrawing, who are crabbier, who have kind of reverted to that need to have everything be exactly the same, or I'm going to keep to my routine. Sometimes you'll see kids just losing it in terms of school. They're not paying attention, they're disorganized, they're not turning in things, and they seem to be just done. And so if you see a child who has been functioning along pretty well, and then suddenly you see things are a whole lot more difficult, that's when you start to ask your questions of, well, what's going on here? And maybe it's because they're depressed, and maybe it's because something happened in school that we don't know about. And maybe it's because all of a sudden school got a whole lot harder, and this child who'd been maintaining with some disorganization and inattention no longer can maintain because they're being asked to do things that are especially hard for them. So we're going to try to figure all that out. If it is depression, what works? CBT. There's also another therapy, but it's hard to locate therapists who are trained in it. And medications. And those medications, interestingly, are the same medications we use for anxiety. So often, if a child has both, we're going to get a twofer off of it. Things, again, to be cautious is that, again, studies are typically not directed toward depression in autism. And we have those same symptoms that we always worry about. And now to repetitive behaviors. So repetitive behaviors are very common in kids with autism. One of the traits that often persists. And we used to think, well, maybe it's because kids are anxious, that they're engaging in the same thing over and over again. And that made sense. That was a good hypothesis. And when we did some limited trials on the medications that we use for anxiety, we saw some benefit in some of the trials. But when we've done the more robust trials, we actually didn't see a difference. Or we saw a difference, to be more specific, that was equal to placebo. So roughly a third of the kids got better on placebo, and roughly a third of the kids got better on SSRIs. So again, when I think about repetitive behaviors, there are times when I actually do think about an SSRI, but I realize what the data is, and I realize that the data is far less conclusive, and I realize that I'm going to have more limited expectations. And again, we're going to do it cautiously. For kids who really have repetitive behaviors that are quite functionally impairing, I think the data is best for risperidone. And we're going to talk about risperidone in just a second, because it actually is one of the medications that FDA has approved for kids with autism. So aggression, self-injurious behavior, and tantrums. These are one of the most significant issues that we face because these are the problems that end up resulting in changes in school and also changes in home placement. And I often see these problems have been there for a very long time, but they aren't such a safety issue when a child is 6. They're more of a safety issue when they're 12, and they're really a safety issue now that we're 16. So what do you do in the moment? Well, one of the things we really recommend is, you make that environment as safe as possible. You remain very calm. You have the most kind of concrete, simple language that you can imagine. You don't take a behavior personally. You offer control. So some of the most effective strategies I've ever used with kids who are on the spectrum are, do you want some cookies? So if they're in the midst of a tantrum, would you like some cookies and milk? Has sometimes remarkable properties of calming a child down because they're in this big frenzy and all of a sudden you've completely distracted them and you've also met a very basic need. We reassure kids that they're safe and that we're here to keep them safe, and we try to work toward that mutual solution. When we think about medications, because parents will say, well, can I have a medication where I can give it to my child when he's in the midst of a meltdown? Well, there are problems. So first of all, it's really hard to get a child to swallow a medication when they're in the midst of a meltdown. They can usually take about 30 minutes to work. The effects can be unpredictable, and so we can have some pretty significant adverse effects, and we need to monitor that. So sometimes we do give those medications. Typically, they're in the context of a complete plan, and often in the context of other medications so that we have some idea of how a child is going to respond to them. And if you truly don't know when that meltdown is going to happen, they're not terribly useful. When aggression and self-injury and big-time mood swings and big-time tantrums are a significant issue, risperidone and Abilify or aripiprazole are FDA approved for the use for those symptoms in kids with autism. So these are FDA approved medications. Risperidone is sometimes known as Risperdal. That's its non-generic name. It is by far the best studied medication of this class in our kids. We've got lots of data, and the data ranges from little kids to teenagers, also to adults. One of the studies that I talked about, the RUP study, had a double-blind, placebo-controlled, multi-site study, again, of kids that had significant issues. And if you look at this, they had a 57% reduction on one of the rating scales that we often use in these research studies versus 14%. 57 versus 14% is a big difference. It is a very big difference. And nearly 70% were considered responders versus the 12% who were on placebo. So what you often see with risperidone is very real. We also saw stereotypies and hyperactivity improve. And when they continued it, 63% of the responders showed no increase in target symptoms, and the dose remained constant. But very few of our medications actually come with no adverse effects. In fact, I can't think of a single one. Maybe melatonin. So we saw an average of about 11 pounds of weight gain in 6 months, and that's not insignificant. The other medication that is FDA approved has much less evidence, but it is also approved for those same symptoms in kids who are 6 to 17 years old. And it was based on 2 8-week double-blind placebo-controlled studies. That's not available as a generic. So these medications are often called neuroleptics or antipsychotics. And the reason that they're called that is because they were initially designed and used for people who had schizophrenia or other psychotic disorders. In certain populations, and these tend to be adult populations with bipolar affective disorder or for some of them for augmentation of major depressive disorder, they've been FDA approved in those situations as well. You usually think of them as in 2 classes, and some of you may be familiar with kind of Haldol or Thorazine. Those are kind of the older medications. We believe that they had a higher risk of some of the adverse effects that we tend to worry about, although it could also be that they were used at much higher doses than we typically use now. And now we have the newer generations, and sometimes you'll hear us refer to those as atypical antipsychotics. Some people will refer to them as second generations. And those are medications like Risperdal, like quetiapine or Seroquel, and like Abilify. And they can often be effective when we have significant self-injury, significant meltdowns, and self-harm. But there are things that can happen with those medications, including weight gain and metabolic problems, glucose intolerance, lipid intolerance, even if there isn't weight gain. Sometimes they can cause people to become very agitated. At times we'll see short-term movement disorders where people become almost stuck. We call that dystonia. Or long-term, potentially permanent movement disorders, and those tend to be small movements. And there are a range of lesser side effects and significantly more side effects. So even though this medication is FDA approved for use in kids with autism, it has probably a much more significant side effect profile than some of the medications that have not been truly studied in this population. And so it's something that needs to be considered. It's always on the table as an option if we have children who require it, but it has to be done with due diligence. And so again, it's this idea of that partnership. Are we weighing the risks? Are we weighing the benefits? Have things changed? Have things changed so much in, say, the course of the year that we're saying, well, you know, this child is no longer engaging in that level of distressing behavior. This child no longer seems to be unsafe. If that's the case, what you're probably going to see with us is we're going to say, well, let's see if we can decrease the dose a little bit and see how that does. And if that works, we're probably going to decrease it even further. Some of the studies that have been done on individuals who were treated with atypical antipsychotics really suggest that in the majority of cases, after a period of time, and usually that time is more than 6 months, we might be able to use a lower dose or sometimes even decrease the medication altogether. But again, that's going to be one of those situations where you're working with your psychiatrist and you're evaluating things and you're deciding, is this the right time? If Johnny is transitioning to a new school system, probably not. If he's been stable in that school system and everything else seems to be stable and he's no longer hurting himself or hurting anybody else, then maybe that's something to start as a conversation. And I think you're going to find that most of us are really quite open to that. So other things that we can talk about, there's a whole wealth of different medications out there. They range from benzodiazepines, and those are medications that we think about like Klonopin. Some people have heard of Valium or Xanax, although we tend to use more Klonopin than anything else. Other people have heard of mood stabilizers. Sometimes those are also called anti-epileptics because those are medications like Depakote that are often used for kids who have seizure disorders. And then there are a number of medications that are currently in trials. And we're currently looking at oxytocin and vasopressin with the purpose of really targeting social interaction. But we won't know very much about those medications for some time to come. Okay? So my last kind of words of advice are come and see us early. Realize that coming to see us does not mean we're going to medicate your child. It means that we're going to try to think through what's causing the problem, and we're going to try to make sure that you know all the evidence behind what might be effective. Medications are going to be one small part of that. That if we both decide that it's reasonable to consider a trial of medications, that's exactly what it is. It's a trial of medications. If it works, if it improves your child's life, if it decreases the distress, if it improves their function, and if they can tolerate the side effects, then that's going to be wonderful. If not, then we're going to need to adjust, and we're going to need to modify what we're doing. And if you say, you know, I think this is making things worse, we're probably going to stop. So it's never a single decision. It's always an ongoing decision. And it's a little bit like sailing. You're never getting there directly. You're always kind of going, well, we're going to go here, and then we're going to readjust, and then we're going to see how this is going, and then we're going to see how this is going. So realize that it's a long-term relationship, and pick somebody you feel you can work with. Okay? So that's pretty much all I have to say.